Hello, and welcome to this Hospice 101, an introduction to hospice care. I'm Stanley Samuel, the spiritual care advisor and bereavement coordinator with Home Hospice of Georgia. I'm going to share my screen so you can see and follow along the PowerPoint that I've prepared for this lecture. In this hospice care, I will be discussing some about palliative care as well, since they both are related, very close in the care that's provided in both fields. So the objectives of today's lecture are to understand the difference between hospice and palliative care, Medicare hospice benefit that is available to all Americans. Then what's hospice prognosis, what kind of prognosis is required to receive hospice care, and then the certification and recertification periods that a person who's terminally ill can receive hospice care and be certified or recertified for another period of time to receive that care ongoing. Then there are levels of care, 4 different levels of care that are provided within hospice care that we'll discuss. Also, what are the services that the interdisciplinary team in a hospice agency provides? So just a brief history about hospice. The word hospitality is the root word for where hospice comes from. And of course, hospitality, primarily in the Middle Ages, medieval times, would be provided in monasteries to people who needed care, especially if they were ill, especially if they were terminally ill. The modern hospice movement is dated back to the 1940s, and Dr. Cicely Saunders is known to be the founder of the modern hospice care. The first modern hospice would be St. Christopher's Hospice in London in 1967, and then the Connecticut Hospice in the United States in 1974. With the Dean of Yale School of Nursing, Florence Wald, being credited to the Connecticut Hospice. Again, in the 1960s, we have, let me move my screen up. I think this may be in your way. Okay. We have Dr. Elizabeth Kubler-Ross writing on death and dying and discussing the 5 stages of grief. Not that these stages of grief occur in sequence of any sort, like denial first, then anger, then depression, then bargaining, and then acceptance. No, they can occur at any point, but those are 5 stages, 5 parts, we may even say, and others can call them as 5 tasks, where individuals who are grieving over their own health and or dear ones who are grieving over the impending death of their dear one and the terminal illness that that dear one has, and all of these stages can be experienced, maybe one without the other, or only one stage may be experienced, and or hopefully they will get to a place of acceptance sooner than later. That is the hope of every counselor. In the 1980s, the United States Congress legislated the Medicare Hospice Benefit, which allows for all Americans to receive hospice care, and Medicare, if they are Medicare qualified, that is they're 65 plus, they would be covered under the Medicare benefit, and to receive hospice care, Medicare would pay for the cost. 2017, there were over 4,500 hospice agencies in the US, so many agencies providing hospice care, but only 1.49, about 1.5 million Americans received hospice care, which is about 0.5% of the United States population. And we know that a lot more people die in the United States. That means they are dying without receiving hospice care and could benefit from hospice care. because as we see here, hospice and palliative care, even though they're different in some respects, they have lots of similarities. Both provide palliative measures, that is comfort measures, that is to provide medications to alleviate pain and thus provide comfort. So both fields, hospice care as well as palliative care, address physical, spiritual, psychosocial, emotional, and bereavement needs of the terminally ill person and or their family. The basic difference is hospice care is provided to people who are terminally ill with a prognosis that two physicians can certify and say this person would not live over 6 months given today's condition. Palliative care is available to anyone, even if they are not terminally ill, as in that they have a poor prognosis of 6 months or less. So both hospice care and palliative care provide palliative measures. The difference is just that if you are in hospice care, you must have a poor prognosis of being having a terminal illness to where you would die within 6 months. Now, that may not happen because none of us has any control over when anybody will die. However, that is the certification that physicians have to give in order for an individual to get hospice care. The hospice benefit is covered under the Medicare Part A, and then Medicaid, which is a state program. Every state has their own Medicaid regulations. The Medicaid per state will have different requirements, but Medicaid would also pay for hospice care. And then commercial insurances also pay for hospice care, whether it's Blue Cross Blue Shield, Aetna, whatever the insurance company may be. They also cover hospice care. They may just have different requirements of documenting and receiving documents to certify and pay for that hospice care. Then there's indigent care available also. Most hospices will provide this to people who are not covered by any insurance and can't be covered by any insurance, and there are no there's no payer source. Most hospices will provide charity care, indigent care in those cases. Let's talk about the diagnoses and prognosis. So diagnosis can be varied: dementia, heart disease, cancer, renal disease. These are the majority or major diseases that we can see, but any disease that has come to its end stage, and physicians can certify you to be to have a prognosis of 6 months or less, then you are certifiable for hospice care. And that's what the prognosis is: 6 months or less, and 2 physicians originally must certify the terminal illness. There are certification and recertification periods. So let's, from referral time, when a physician says, okay, there is an end stage of this disease, this person, we cannot provide any more aggressive treatment, there's nothing else we can do per se for this individual, that's when the referral to hospice would be provided by that physician, and the hospice liaison, which could be a healthcare coordinator, a patient and family liaison, a patient care coordinator, different terminology that different hospice agencies may use, basically gets in touch with the patient and or the patient's power of attorney, POA, and consents have to be signed by the patient or their POA to elect the hospice benefit based on this referral that a physician has provided. And then once that referral is pursued on and the hospice patient or their POA has signed consents to accept hospice care, then the hospice medical director can also has to certify. So we have the referring physician and the hospice medical director both then certifying to terminal illness. That's called the certification of terminal illness, that this person, given today's condition, would not live for more than 6 months. And then, of course, like I said earlier, nobody can determine how long an individual will live. We can, physicians and medical personnel can only go by their experience of a given disease and say, this is what it seems to be the stages that this disease will go through. But there are benefit periods. That is, once the physicians certify, there's a 90-day period, which is 3 months. And after the 3 months, a physician, which is in this case now, only one physician is needed, the hospice medical director, given all of the different team members input on what's the condition of the patient within those 90 days. At the end of that 90-day, the physician must certify again, which is called the recertification period, that this person is still terminally ill and given today at the end of the 90 days would not live more than 6 months. But the person could live longer, and then there's another 90-day period from that first certification period where recertification must be done again. The physician must again lay eyes on the patient and certify for 90 days. After the first two 90-day periods, Medicare recertification periods are 60-day periods, 2 months each. The physician must recertify along with the interdisciplinary hospice team members that this patient is still not going to live more than 6 months. And it's to infinity, as you can see on my slide, which means as long as the person, given the end of the 60-day period, is still terminally ill, as in they have not improved in any way, and they continue to show signs and symptoms of decline, then the physicians can recertify that individual to continue to receive hospice care. Those are your recertification periods. And of course, reimbursements do decrease as the patient continues to be on hospice care. The hospice agency receives lesser money, but must continue to provide the same care that the patient and family deserve. So what are the levels of care? There are 4 levels of care in hospice. The routine home care is the most commonly used level of care, which means the patient has come on to hospice service and they are at home, whatever their home is, whether it's a senior living place, a personal care home, their own personal residence, an assisted living community, a nursing home, wherever the patient resides, that's their home, and hospice staff would visit the patient in that home, place of residence, and provide care. That's routine home care. It's the lowest level of care, or the general level of care. Then there's respite care available. This is usually for a 5-day period where the hospice agency, whether it has its own inpatient unit, a standalone, or within some kind of a facility, a unit with beds that can be utilized by hospice patients, or they may contract with another agency that has such a building, and the patient is moved from their home place of residence to this facility for 5 days normally, so that the family can get respite. The family can get a break and relax, travel, or visit with the patient in the facility if that's what they want to do. But it's respite, a time of break for the family, because when you're caring for terminally ill individuals, even if they're family, it's very stressful and it can be very tiresome. So in order to prevent breakdown, hospice agencies provide respite care. Then there's continuous care if the patient's symptoms are uncontrollable and the pain is not being controlled, and they're showing signs and symptoms, that a nurse must be present to provide care for longer than just an hour-long visit. Then continuous care is provided during this time. Remember, in routine home care, the hospice staff visit the patient. It may be a 45-minute visit, 30-minute visit, 1-hour visit, but then they go away and they don't stay in the home of this individual. But during continuous care, the nurse, an RN or a certified nursing assistant, and different team members must continuously sit with the patient by the patient's bedside, because symptoms are uncontrolled and they need to be monitored, and they make documentation of every 30 minutes or so to say, what is the condition of the patient? Is it improving? Is it declining? And if the patient continues to have pain symptoms or other symptoms that need management by medical personnel, then that continuous care continues. Normally, a continuous care is for 24 to 72 hours. but it depends on the condition of the patient. And as the patient's symptoms get controlled, then continuous care is ended at that time. Inpatient care is similar, as in it is for symptom management again, that the patient's pain is not being controlled or some other symptom is not under control. But in this case, in inpatient care, patient is moved from their place of residence to an inpatient facility where there are beds again, just like we said for respite care. But in this case, it's a higher level of care that the patient is in, and symptoms are being managed. They're not just there to give the family a break. They're there for their symptoms to be managed. And that's called the general inpatient status that the patient is in. And it can, again, be 24 to 72 hours to a week. It depends, as long as the patient's condition is continuing to need symptom management. Inpatient care is provided, and once their condition is stabilized, the symptoms are managed, they are then transported back to their own place of residence. Let's talk about the interdisciplinary team that forms the hospice team, or that a hospice agency must have on board. So of course, a medical director, a physician, must be part of the interdisciplinary team. Then there are registered nurses and licensed nurses, so RNs and licensed nurses, or LPNs, that is, are part of the team, must be part of the team. Then certified nursing assistants, CNAs, must be part of the team. Medical social worker. The medical social worker may be a licensed medical social worker or a licensed clinical social worker. But either way, a medical social worker must be part of the team. And then a spiritual or bereavement care provider, coordinator. Different hospices use different specific disciplines. I am the spiritual care advisor and bereavement coordinator. Both roles are put together. So the Medicare benefit conditions of participation in the hospice Medicare benefit require somebody to be there on the interdisciplinary team to provide spiritual and bereavement support. But one or the other is acceptable. So usually, if it's a smaller hospice, they will have the chaplain or the spiritual care advisor also be the bereavement coordinator, and vice versa. Then there are volunteer services. A hospice may have a volunteer service coordinator, or at least have volunteers that are recruited by the team. And 5% of patient contact hours, that is, all the team members that visit the patient, 5% of those hours that are being reported as patient visits must be done by volunteers. So it's a requirement of Medicare COPs, conditions of participation. Then a dietitian should be on the team. They could be, depending on the size of the hospice agency, contracted or full-time individual, paid employee, that is. But a dietitian for especially people with esophageal or those kinds of conditions where swallowing is an issue or diet is an issue, dietitian consultants must be available to the patient and family. Then music therapists can also be part of a hospice interdisciplinary team, that is. Music therapists are not required by the Medicare as of right now. However, a lot of hospices hire music therapists to provide music therapy. It's a little different from just somebody singing or somebody playing music. Music therapists are trained and certified to provide therapy. And it's a little different from just providing therapeutic music. So the interdisciplinary team, which includes all these different discipline members, must meet by Medicare guidelines every 14 days to discuss the patient's condition and update the POC, or plan of care, as to what was done in the last 14 days and what will be done in the next, what is the plan for the next 14 days to provide care to this patient. Hospice services then, of course, include all these different disciplines, interdisciplinary team members providing services. So the physician services, visits as needed, or at least at the 90, 60 day certification and recertification points. The physician must, or their assistant, physician assistant, or a nurse practitioner that works with that physician must visit the patient and provide that support, and also be able to use that visit to certify or recertify patients' terminal illness. Then registered nurses have to visit the patient once at least every 14 days. One visit must be made by a registered nurse. That's a requirement by Medicare. Then certified nursing assistants, they could visit 1 to 5 times a week as needed, PRN, per requested need, the patient's condition, the family's need. Some families want every day of the week, that is at least 5 days of the week, to have the CNA come and provide support in bathing, in cleaning up the patient, and that kind of care certified nursing assistants provide. Um, uh, it's again based on the need of the patient. It could be just once a week. Some families don't want that many people visiting, and they just want once a week. The CNA can come, or twice a week. So, and depends on each family and patient's needs. Then medical social workers, spiritual care advisors, music therapists, all psychosocial disciplines visit at least once or twice a month, if the or as needed, if the patient desires. These are not required visits, as in the patient in the first 5 days to a week time of the patient coming on service. It's required that each discipline do their assessment and reach out to the patient and family and see what their needs are, whether it's for social services, for spiritual needs, or if you have a music therapist on the team, then for those and or volunteer visits if the patient wants, or if the family wants or does not want. If the family, it's the family's choice to decide and say, well, we don't want the chaplain visiting every month. They've visited once, or they called me and I don't really want them to visit at all. That's a choice they can make. Families can make that decision, and the chaplain or social worker can just be available as needed, PRN, per requested need. Same with volunteers, as I've said. And then hospice also provides for transportation to and from respite care, or the general inpatient care that we talked about, to a facility. It's the hospice's responsibility to transport the patient in a medical transport and bring the patient to that facility, and then bring them back after 5 days, or whatever that time period is, back to their place of residence. Then hospice services also include medical supplies, which include medications related to the hospice diagnosis. So vitamin B may not be paid for by the hospice, but any medication that is related to whatever the hospice diagnosis is, meaning if the patient is on hospice because of a cancer, or because of dementia, whatever that disease is, any medications related to that disease process and to provide care to the patient and comfort to the patient would be paid for by the hospice agency, but not anything else. So most hospice agencies will narrow down medications to what needs to be provided now to this patient to provide comfort, not any kind of aggressive medications. Then there's durable medical equipment that's available to the patient and family. That is a hospital bed, it could be a wheelchair, it can be a bedside commode, pressure pads, low air loss mattress, a Hoyer lift, and similar things like that, or other medical equipment that is necessary, an oxygen concentrator, oxygen tanks if they are in need of respiratory support. Those kinds of durable medical equipment is paid for by the hospice and provided to the patient while they're on service. Then continence and hygiene supplies that support activities of daily living, ADL, gloves, adult briefs, pull-ups, etc., wipes, those kinds of things. Lotions are provided by the hospice. Again, this is not for beautification, but for healthcare needs to support the patient skin turgor and skin health. When I mention lotions, that is. I had some questions that were submitted to me, and I'll go over those, but please feel free to ask questions. You can email them to me at samuels@homehospicega.com. That is SAMUELS at HOMEHOSPICEGA.com. Samuel S. at Home Hospice Georgia with just ga.com. So the questions that have been asked is, what is the purpose of hospice care? I've discussed this as in to provide care for terminally ill patients or individuals who can be certified to have an illness with a prognosis of 6 months or less. And then what is the difference between hospice and palliative care? We discussed as well. The simple, basic difference is while both hospice and palliative care provide palliative or comfort measures, pain relieving measures, hospice care is simply different in that it can be provided only to people with a prognosis of 6 months or less in their terminal illness. Then who are the most common users, I should say, not uses, users of hospice services in terms of demographics? Mostly, of course, it's people of 65 years or older, and most of the hospice users by research happen to be of the female gender, and also they happen to be Caucasians. A lot of other ethnic groups and or cultural social groups use hospice lesser. So then the question is, what are some reasons that cause individuals not to accept hospice care? Mostly the reasons are related to reluctance in accepting a terminal illness when the medical professions say, well, there's nothing else we can do. This is a terminal illness. The natural reaction for a lot of people is, well, let me get a second opinion. Let me go somewhere else and find out. And it's fair. There's nothing wrong in that. However, that reluctance can cause the disease to have progressed to such a place where the patient actually dies sooner, in one sense, than having received comfort care and lived a little longer. Because when you're comfortable spiritually, emotionally, mentally, your human body also responds, and you feel better, and you heal better, and you live longer, a healthier life. So that reluctance, and to the reluctance to forego any kind of procedures, aggressive treatments that might possibly be available out there, causes people to not choose or accept hospice care. There can be a simple reluctance to accept that death is real and it's going to happen, and it's sooner than what we expected maybe. Another question is, what happens to hospice patients if they begin to recover in health? This happens sometimes, like I said, as patients go to their place of residence. They're mentally, emotionally, spiritually, socially in their comfort zone. They feel better, they heal better. They actually could, at the end of the 90-day period, or the second 90-day period, or the 60-day, whichever recertification period, could be at a place where they are stabilized in health. They don't have any symptoms that need to be managed. They are actually improving in health instead of declining in health. When the interdisciplinary team members visit, the patient continues to do better. Maybe they could not walk when they first came on hospice service, and now they are walking around, even if it's with the assistance of a walker. They are walking around, they're eating independently, they are eating more, they're gaining weight. All of these things can say, well, the patient's health is improving. And at that point, the physician medical director of the hospice, given the nurse's report and the interdisciplinary team members' report, cannot recertify the patient with a prognosis of 6 months or less. And in that case, the hospice would give a 14-day notice to the family that they're going to have to discharge this patient, which is a good thing. We call it graduating from hospice, that the patient has improved in health and they're going to live a little longer. Again, none of us knows, so the hospice must discharge the individual. Now, if and when that disease process continues, which the disease process doesn't change per se, it's just they are feeling better. A week later, a month later, 3 months later, 6 months, even years later, they may again have come to that stage of decline, and at that point they can receive hospice care again. Who covers the cost of hospice care? As I mentioned earlier, Medicare, for all Medicare people who are on Medicare, usually that would be 65 and up, are covered by Medicare for their hospice costs. Then Medicaid, state Medicaid programs, if anybody is certified for Medicaid, then they would get covered for their hospice costs under Medicaid. And then the commercial insurance companies also cover and pay. And if there is no insurance that the patient or family has, then most hospices will take care of individuals in need as an indigent case, as a charity situation, and will provide hospice care. What types of people, what are the personality traits of hospice care professionals, people who work in hospice care? Of course, every discipline has their own requirements of certifications in their own disciplines, but the personality traits have to be people who like the older population, geriatric population, working with older people, and then have a sense of acceptance and level of comfort with death and dying, because in hospice care, death and dying occurs just about every day. And as staff members, as hospice care providers, different interdisciplinary members have to deal with death and dying just about every day and very often. And it can be too much. And people do leave hospice care from being a hospice care provider. They leave that discipline for some time. Sometimes people take a break, and different things can be done, of course, but you must have a good sense of acceptance of death and dying. These are the references that I've utilized in preparing this lecture. I will leave you with that. Blessings and peace. Again, if you have any questions, please don't hesitate to reach out to me and or go to our website as well, homehospicegeorgia.com. My company's name that I work for, the agency's name is Home Hospice of Georgia, and my email address again is samuels@homehospicegeorgia.com.